Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Madrigal Pharmaceuticals.
For endocrinologists across the country, the waiting room is full of patients at high risk for an often silent liver disease, and most have never been screened. MASH, or Metabolic Dysfunction-Associated Steatohepatitis, is the hepatic consequence of the same metabolic complications you see in your patients every day: obesity, insulin resistance, type 2 diabetes, and dyslipidemia. But here's the reality. Most patients with MASH don't feel their fibrosis advancing. Some have no symptoms at all. And until recently, endocrinologists haven't had a clear roadmap for action or approved treatments to act with. But that's changed. Welcome to Medscape's in-depth CME TV docuseries, Managing MASH in the Modern Era, the Endocrinology Edition. I'm your host, Taryn Winterbrill. Today, we're in New York City, home to Dr. Priya Jaisinghani. With a nod to New York City's vibrant theater scene, Dr. Jaisinghani is what folks in show business might call a triple threat. She's board certified in internal medicine, obesity medicine, and endocrinology. She's also an international speaker, a clinical assistant professor, and a leading voice at the intersection of metabolic medicine and liver disease. In this episode, she'll show us how metabolic dysfunction and liver disease are linked and how to identify patients with clinically significant risk for MASH. Dr. Jaisinghani, thank you so much for having us here.
Please call me Priya, and I'm so happy you're here. I've been passionate about this topic for years.
Awesome. Let's get started then. Could you briefly explain the difference between MASH and MASLD, or metabolic dysfunction-associated steatotic liver disease?
Sure. And because the terminology has evolved, it's an important distinction to make. MASLD is the umbrella term. It covers the full spectrum of metabolically driven steatohepatitis. MASH is a subset of MASLD with active inflammation, hepatocyte injury, and typically some degree of fibrosis. Once a patient with MASH reaches F2 or F3 fibrosis, the risk of progression to cirrhosis and its complications becomes much higher.
So in the context of endocrinology, why does the topic of MASH matter so much right now?
It matters because endocrinologists are on the front lines of metabolic diseases. Every day, we see patients living with obesity, type 2 diabetes, prediabetes, dyslipidemia, and these are precisely the patients at the highest risk for MASH and its complications. What we haven't always been doing is connecting those metabolic dots to the liver. And now we have FDA-approved treatments shown to slow fibrosis progression and in some patients even improve fibrosis staging. Finding and treating these patients early enough means we can potentially stop the disease before it causes extra hepatic complications and permanent liver damage.
So with that framing in mind, let's introduce a hypothetical patient. Can you kindly describe someone you might see in your clinic who fits the profile we're talking about today?
Sure, I'll describe a patient I see often. Let's call him Marcus, a 52-year-old male who is living with obesity with a BMI of 34, type 2 diabetes with an A1C of 7.2, and hyperlipidemia. His PCP recently started him on semaglutide 0.25 milligrams weekly for his diabetes and referred him to me for metabolic optimization. He's also on metformin 1,000 milligrams twice daily and atorvastatin 40 milligrams daily. During intake, he remembers being told years ago that he had some fat in his liver, but they told him not to worry about it as long as he was eating better. According to his history, he's never had a workup specific to his liver.
So what raises concern for liver fibrosis in a patient like Marcus?
Several things. First, Marcus has what I like to call metabolic multimorbidity, living with obesity, type 2 diabetes, and hyperlipidemia, which can drive inflammation, insulin resistance, hepatic fat accumulation, and patients living with type 2 diabetes in the United States, the prevalence of MASLD is more than 70%, with approximately half living with MASH. And type 2 diabetes in particular is one of the strongest independent risk factors for fibrosis progression in MASH. The liver is reacting to the same metabolic dysfunction we're already treating as endocrinologists. Secondly, that comment, don't worry about it when it comes to the liver, that's a missed opportunity. The optimal time to intervene is before a patient develops F2, F3 fibrosis. In fact, the earlier, the better. Once patients progress further, the risks become high for complications such as cardiovascular and liver-related mortality. In fact, cardiovascular disease is the #1 cause of death in patients with MASH, not liver disease.
So the stakes are high. What's the role of the endocrinologist specifically in MASH screening, and where does it start?
It starts with identifying who to screen, and for endocrinologists, this could be most of our patients. Based on the AGA updates to the MASLD care pathway, the high-risk criteria for MASH can include anyone living with type 2 diabetes, those who are living with overweight or obesity and have at least one additional metabolic risk factor, such as prediabetes, hypertension, or dyslipidemia, and anyone with steatosis or elevated liver function tests. When I shared that recently at a conference, a colleague raised her hand and said, "So you mean you basically screen everyone for MASH?" And my response was, almost, because in my endocrinology practice, nearly every patient who walks through the door meets the criteria for high risk for screening.
Marcus checks several high-risk boxes: type 2 diabetes and obesity with at least one additional metabolic risk factor, in this case, hyperlipidemia. And yet, like so many patients, he's never had a formal liver workup. Current guidelines are clear. Any patient who meets the high-risk criteria Dr. Jaisinghani just described should be evaluated for MASLD and risk stratified for MASH using non-invasive tests. Okay, so let's dive deeper into evaluation. What do the guidelines recommend for risk stratification in endocrinology practice?
The ACE, ADA, and AGA guidelines recommend a two-step non-invasive approach. The first step is to calculate a FIB-4 score. You can find FIB-4 calculators online for free, and you need only the person's age, AST, ALT, and a platelet count. It's simple, and it's your first filter to identify patients with likelihood of significant fibrosis. A low FIB-4 below 1.3 in adults under the age of 65 or below 2.0 in older patients is reassuring. Those patients can be monitored with follow-up generally every 1 to 2 years. A FIB-4 of 1.3 or higher requires further evaluation.
And what comes next for someone with an elevated FIB-4?
The second step is liver stiffness measurement, typically with vibration-controlled transient elastography or VCTE. At NYU, I was involved in getting VCTE into our clinic. It took 4 years, but we have one.
Excellent. Good for you. How do you use it?
So VCTE measures liver stiffness, which correlates with fibrosis staging, and also captures the controlled attenuation parameter, or CAP score, which measures how much fat tissue is in the liver.
But what if VCTE isn't readily accessible?
If VCTE isn't readily accessible or available, or when results don't quite fit the clinical picture, you have an option of getting other testing, such as the Enhanced Liver Fibrosis Test, or ELF test. It's a serum-based panel that gives you another read on fibrosis severity.
And how do you interpret those results, and what cutoffs guide your decisions?
Great question. So for liver stiffness on VCTE, a measurement at or above 8 kPa suggests significant fibrosis compatible with F2, F3 fibrosis and high risk of progression. This is a stage where FDA-approved MASH treatments are indicated. Below 8 kPa is low risk, and VCTE can be repeated in 3 years based on guidelines and the patient's clinical picture. For ELF, below 9.2 is lower risk, and at or above 9.2 is a rule-in threshold for significant fibrosis. This is the new AGA guidance released in early 2026.
Are there factors that can affect the accuracy of these tests? Things clinicians need to watch for?
Absolutely, Taryn. So for FIB-4, age affects the cutoffs. The higher threshold for patients over 65 reduces false positives in older adults. For VCTE, particularly above a BMI of 40, there can be an overestimation of liver stiffness. For a BMI above 30, you can consider using a probe that is specific to that population, or even another imaging modality such as MRE.
And how would you sequence these tests for a patient like Marcus?
So in my practice, I go broader than just liver testing from the start because I'm in the metabolic space. So when a patient like Marcus comes into my office, we do a comprehensive clinical intake, a 4-page metabolic questionnaire, a history, lab and imaging workup, and I even take some other measurements like neck, hip, and waist circumference. So waist circumference is critically underused. It's a direct marker of visceral adiposity, and cardiometabolic risk. From there, I use the labs to calculate a FIB-4. If it's indeterminate or elevated, so a patient like Marcus can go to VCTE. If results are discordant or VCTE isn't accessible, I use ELF. The goal is really to reach risk stratification that is actionable.
And then at what point does an endocrinologist refer to hepatology?
So this can also be based on comfort level, but for patients with F2, F3 fibrosis, we as endocrinologists can initiate treatment and co-manage the patient alongside GI hepatology. We now have 2 FDA-approved treatments for MASH with F2, F3 fibrosis, and both are squarely within our wheelhouse. The first is resmetirom, which works through thyroid hormone receptor signaling in the liver. The second is semaglutide 2.4 milligrams weekly, which is a GLP-1 receptor agonist we have already used for patients living with overweight and a weight-related comorbidity or obesity, but now also approved for MASH. Once you move beyond F3 towards cirrhosis, those patients need hepatology as a primary manager for surveillance and specialized care. But for F2, F3, we should and can be managing alongside GI and hepatology if we feel comfortable.
Let's close the loop on Marcus. He presented living with obesity, type 2 diabetes, and hyperlipidemia. On his metabolic panel, his AST is 48 and ALT is 52, with a platelet count of 196. Those values give him a FIB-4 score of approximately 1.8, above the low-risk threshold of 1.3 for his age, and this signals that further evaluation is needed. So with a FIB-4 of 1.8, what's your next step for Marcus?
So Marcus would get a VCTE, and let's say his liver stiffness comes back at 10.2 kPa with a CAB score of 320. That's moderate to severe steatosis and a stiffness measurement consistent with F2, F3 fibrosis, which means Marcus has MASH with F2, F3 fibrosis as a patient we need to treat.
And what that treatment conversation looks like for endocrinologists is exactly what you and I will cover in our next episode.
I know, and I'm excited to have you come back.
Likewise. But before we close this episode, what are the 1 or 2 key takeaways from today that you want every endocrinologist watching to walk away with?
First, we need to recognize that many of our patients may already be at high risk. If someone has high-risk conditions such as living with type 2 diabetes, living with overweight or obesity, one additional metabolic risk factor, they need to be screened for MASH. And that shouldn't be an add-on. It's a part of comprehensive metabolic care. Second, the path to diagnosis can be practical and accessible. You can start by calculating a FIB-4 with labs you may already have. If it's above 1.3, you can get a VCTE or ELF test. If it's below, remember, you have to reassess in 1 to 2 years. Right now in MASH, we're facing not only therapeutic inertia, but screening inertia. People aren't screening and patients are silently progressing. We have tools to change that.
Priya, your message is clear and urgent, and it couldn't come at a better time. Thank you so very much for joining us and for your leadership in this space.
Thank you. I really hope everyone feels empowered to have that conversation about liver health with their patients. And it doesn't have to be complicated. It can start with the willingness to care for the whole person and use simple tools like FIB-4.
To recap, MASH screening in endocrinology follows a 2-step non-invasive approach, making it possible to find these patients early and act on what you find. In our next episode, Dr. Jaisinghani takes us from diagnosis to treatment, walking through the full management picture for patients with MASH, including the 2 FDA-approved therapies now available. Until then, think about your Marcus. He's already there, sitting in your waiting room, waiting to be found. On behalf of Medscape, I'm Taryn Winter-Brill. Thank you so much for joining us for this episode of Managing MASH in the Modern Era. Please complete the post-activity quiz and evaluation to receive your CME credit.